Hey everybody, today we're going to be talking about theories and treatment of abnormality in chapter 2 of the Susan Nolan Hoeksema book. So we'll be talking about biological approaches, psychological approaches, sociocultural approaches, prevention programs, and then common elements and effective treatments. So Steve Hayes defined theory and therapy. So he defined theory as a set of ideas that provides a framework for questioning, gathering, and interpreting information about a phenomenon. So this is kind of your global way of thinking about things. This is usually based upon some information, and then you can derive hypotheses based on the theories that you formulate. So this would be kind of like the theory that the Earth is round, and therefore you would try to verify that using experiments. Therapy, on the other hand, is a treatment that addresses factors that a theory says causes the problems, or the phenomenon. So depending on what you theorize to be the cause of the problem depends on the type of intervention that you'll choose. And we're going to talk about interventions in this lecture. So the main way that we look at things in psychology is what's called the biopsychosocial approach. It's a combination of biological, psychological, and sociological factors that result in the development of psychological symptoms. So they're referred as risk factors because they increase the risk for psychological problems. So basically what we say is that people generally who develop psychopathology have some sort of biological predisposition. It means that they were born with increased likelihood for developing that disorder. They have some psychological vulnerabilities, and there's some stressors, some sociocultural factors that have occurred that kind of manifest themselves, and therefore the expression of the biological predisposition takes place. So transdiagnostic risk factors are those that increase the risk of multiple types of psychological problems. So some people are at risk for different types. Some of them are very specific, and some of them are more broad. So you'll often hear talk in psychology about the diathesis stress model of the development of disorders. So the diathesis is the kind of the biopsychosocial part of it, your risk factors. Then we have the stress, like a biological trigger such as the onset of a disease, exposure to toxin, social triggers such as a traumatic event, a major loss, or a psychological trigger like a perceived loss of control or a violation of trust, and therefore the disorder occurs. So biological triggers, I've heard people with schizophrenia say, that their schizophrenia developed after they did acid or after they smoked a lot of marijuana. I mean, that's to be debated, but that might have been a trigger for them. Social triggers could be, for somebody in combat could be, being in a very horrific accident, seeing something horrible. And psychological triggers could be something like, somebody you trusted violating, not, living up to their expectations. So we're going to start with a bit of a discussion about the brain and biological theories. You've probably all heard of Phineas Gage before. He was a railroad worker in Vermont, and during the course of his work one day, they were exploding rock, making new railroad, and a gauge or a rod went through his frontal lobes. It's debatable whether it's both frontal lobes or just the left one. But as a consequence, he lived. It looks quite horrific. But there were significant changes to his personality, which were not obviously accurately described because this happened a long time ago. But people reported that he was no longer Gage anymore. And basically the frontal lobe of the brain is the one that kind of is in charge of planning and controlling your behavior. It's kind of your filter, for lack of a better word. And so we become much more impulsive if there's any kind of damage to our frontal lobes. And so that's what people noticed, that became more aggressive. He would engage in fights more. He would have these kind of cockamamie schemes. He wouldn't follow through with them. And he had a hard time resisting his sexual urges, etc. So some of the causes of abnormality from a biological perspective are brain dysfunction, where there's actually something wrong with your brain, chemical imbalances, where there are problems with the neurotransmitters in your brain, and then genetic abnormalities. So the brain is organized in three main structures: the forebrain, the midbrain, and the hindbrain. The forebrain is comprised of the thalamus, hypothalamus, pituitary gland, limbic system, and cerebrum. The superior and inferior colliculus and the substantia nigra are in the midbrain, and then the medulla pons, reticular formation, and cerebellum are in the hindbrain. So these are, you can kind of see they're located at different parts of the brain, the forebrain being kind of the top, the midbrain in the middle, and the hindbrain at the bottom. So here's a different observation of where these are and some of the causes of it. So you'll see in the hindbrain, the cerebellum is involved in controlling movement and balance. The pons and reticular formation are related to sleep and arousal patterns and attention. And the medulla is responsible for regulating unconscious functions such as breathing and circulation. That's why oftentimes if people have trauma to the back of the skull, that they die because the medulla is damaged and therefore they can no longer breathe. The corpus callosum are the fibers that pass between the two hemispheres of the brain. People who had severe seizure disorders, they used to cut these fibers so that the seizure couldn't pass from one side of the brain to the other. It's not usually done anymore, but it had been done previously, only in very severe cases. And then the forebrain is generally some of the higher functions, like the cerebral cortex does most of our advanced thinking. The thalamus is just the ingoing and out is the kind of the relay center. The hypothalamus regulates our basic biological needs like hunger, thirst, and temperature, and the pituitary gland regulates our endocrine system or our hormones. So here are some more pictures of the brain. You'll see there are different fissures that divide the different areas of the brain. You can see on the right hand the corpus callosum, which is dividing the right and the left half of the brain. If we look at the brain on the left, from the side part, you'll see the different lobes of the brain. The frontal lobe is the one that we talked about before. That's kind of by your forehead. That's in charge of kind of our planning. Then we have the temporal lobe, where we have our language, our auditory process, so Wernicke and Broca's area. Our visual cortex is in the occipital lobe, so that's where we do our vision from, so damage there could result in blindness. And then our parietal lobe is on the back, and then our sensory cortex is right on top. So the limbic system is a set of structures that regulate many of our instinctive behaviors, such as our reactions to stressful events and our eating. So it's located around the central core of the brain and closely interconnected with the hypothalamus. And the amygdala is the structure of the limbic system that is critical in emotions such as fear. And so damage to this part of the brain can actually result in people no longer experiencing fear, even in dangerous situations. So these are very important because historically we needed to have fear to protect ourselves from our enemies. The hippocampus is the part of the limbic system that plays a role in memory, so damage here can result in memory problems. So here you can see that there are different areas of the limbic system, and the hypothalamus and the amygdala kind of being located more in the middle, as well as the hippocampus. So we talked about earlier neurotransmitters. So neurotransmitters are the little kind of dots on the right-hand picture that pass between the two kind of synapses of our neurons. We have millions and zillions of neurons in our body, and in order for messages to be passed through, both kind of information, but it can also be information to our muscles. We have neurotransmitters that are passed through the axon, and then from one dendrite to another, and therefore that's how we transmit messages. And when we have a degradation of the myelin sheath, which surrounds the axon, which happens in multiple sclerosis, oftentimes these messages can no longer get out to our muscles, and that's why you see some of the physical problems that people have when they have multiple sclerosis. So neurotransmitters are the biochemicals that act as messengers, carrying impulses from one neuron or nerve cell to another in the brain or other parts of the nervous system. The synapse or synapse is the slight gap between the synaptic terminals and the adjacent neurons. So if you go back to the previous picture, so that's the synaptic gap, is the space between the two neurons on the right. And the receptors are molecules in the membrane of the adjacent neurons that kind of accept the neurotransmitters. So processes that re-affect the neurotransmitter. So reuptake occurs when neurons that initially release the neurotransmitter into the synapse reabsorb the neurotransmitter, decreasing the amount left in the synapse. So usually the neurotransmitter passes from one neuron to another, but if for some reason there's reuptake, that decreases the number. Degradation occurs when the receiving neuron releases an enzyme into the synapse that breaks down the neurotransmitter into other biochemicals, and therefore the signal cannot keep passing through. Whoops. So biochemical imbalances can cause psychological problems, and these can be caused by the number and functioning of receptors for neurotransmitters on the dendrites, or malfunctioning of the neurotransmitter systems. So we have different types of neurotransmitters that are related to psychological disorders, and you've probably heard about some of these because many of them are implicated in the major mental disorders such as depression, schizophrenia, for example. So serotonin is often linked to kind of mood and feelings like that. So that travels through many key areas of the brain affecting functioning in that area. Dopamine has been associated with Parkinson's disease. If you have too little of it, and too much of it is associated with schizophrenia. And it's found in the areas of the brain associated with experience of reinforcement or reward, and it's affected by substances like alcohol that are found rewarding. Norepinephrine is produced by neurons in the brain. Cocaine and amphetamines prolong the action of norepinephrine by slowing its reuptake process. And gamma-aminobutyric acid, or GABA, if you don't want to try that word, I was actually feeling a little brave at the moment, inhibits the action of other neurotransmitters, and it gives a tranquilizing effect because they increase the inhibitory action of GABA. So we're going to be talking about different kinds of neurotransmitters throughout the semester because different ones are implicated in different disorders. So here's a picture of our endocrine system. This is our hormone system. It starts with our hypothalamus and pituitary gland, which then talk to the thyroid gland and parathyroid gland, which release the hormones. Pancreas and adrenal glands also release hormones, as well as the ovaries and testes in males. So there are systems of glands that produce chemicals called hormones released directly into the body. And hormones carry messages throughout the body and can affect your mood, your levels of energy, your reactions to stress. We hear in females they have premenstrual dysphoric disorder, or PMS, premenstrual syndrome, a lesser form. They're not trying to pathologize PMS. But we know that women report that they have changes in their energy, their mood, their reactions to stress as a consequence. Also, a time when women have a lot of mood swings is during pregnancy and the postpartum period, and that's when your hormones are kind of awry. So you can see that your hormones have a lot of influence on your psychological functioning. So the pituitary gland produces the largest number of different hormones and controls the secretion of other endocrine glands. So malfunctioning of the HPA axis, the hypothalamic pituitary adrenal gland axis, causes anxiety or depression. So, when you have some of these systems that are out of whack, one of the first symptoms that we can observe sometimes is depression. And so one of the things that doctors often do when people report kind of a sudden onset of depression is to check their thyroid to make sure that it's producing an adequate number of hormones. So behavioral genetics is the study of genetics of personality and abnormality, and is concerned with the following questions. To what extent are behaviors or behavioral tendencies inherited? What are the processes by which genes affect behavior? So if you think about it, there are a lot of characteristics that you probably share with your parents, and it's not clear how much of those were innate and that you were born with them, or how much of this was actually something that developed because you saw them. So behavioral geneticists look at your genes to see how much of your behavior or your psychological symptomology is related to what's contained in your DNA. So here's a picture of our chromosomes. You probably all remember this from biology class. We have our DNA, our RNA, and so we have different genes. There are different lengths of RNA. So gene abnormality can be associated with a lot of psychological disorder. It's usually a polygenic process, meaning that there are multiple genetic abnormalities that are coming together to create one specific disorder. So it's not specifically one gene necessarily, but a malfunction of several. We also talk about the interaction between genes and the environment, because we know that genetic factors are found to influence the kinds of environments which are chosen by people, which then reinforce individuals' genetically influenced personalities and interests. So basically what this is saying is that we self-select, people who who genetically are more outgoing, more exuberant, are more sensation-seeking, tend to, might live in downtown Manhattan. People like me, who like the peace and quiet, will tend to retreat more to the country, and therefore there's an interplay between our genes and our personality. So environments act as a catalyst for genetic tendencies. So epigenetics are environmental conditions that affect the expression of genes. And so, for example, putting me in different environments, I may be predisposed to not handle stress very well, and therefore environments that have a lot of noise and a lot of pollution or whatever may cause the expression more of the poor stress handling gene, for example. Environments can modify the DNA to turn on or off. So in terms of biological therapies, you've obviously heard of pharmacology. Some of you may even be taking medications. So drug medications can be used to help improve neurotransmitter systems and functioning. Medications such as anticonvulsants, which were traditionally used for seizure disorders, actually have been used to treat mania, and they have fewer side effects than lithium, which was traditionally prescribed. Lithium is very hard to balance, and so people have to go for blood work regularly, and there are a lot of foods that they have to avoid. You'd be surprised to know that people actually still do electroconvulsive therapy, and that for very severe cases of depression, people still engage in ECT. We don't still know exactly why it works, but it's a lot more humane process than what you saw in One Flew Over the Cuckoo's Nest, in that it's only done unilaterally on one side of the brain, and people are put under general anesthesia as well as given a muscle relaxant, so very little is observed, and we're finding very little memory loss associated with it compared to much more significant loss in the past. There are other things such as deep brain stimulation, vagus nerve stimulation, where people are actually having electrodes implanted into their brains, and these are for cases of very severe depression. And we have psychosurgery. These are very rarely used and only with people who have severe disorders that do not respond to other types of treatment. So I mentioned earlier cutting of the corpus callosum. So, for example, in very severe seizure cases, they would do something like that and cut the corpus callosum, but it's really not practiced commonly today. One of the Kennedys, JFK's sisters, actually was, I guess, was slightly, delayed, and was having behavioral problems, and so at the time the doctor recommended a lobotomy where they kind of removed the frontal lobe, and her behavior became completely dysregulated after that, as we learned about in Phineas Gage, and she had to be institutionalized for the rest of her life. So obviously that's not being done anymore. There are different types of drug therapies for mental disorders. So there are antipsychotics, which are used to reduce the symptoms of psychosis, antidepressants, which reduce the symptoms of depression. Lithium reduces symptoms of mania, and anti-anxiety medications reduce symptoms of anxiety. So the common examples are on the right: Thorazine, Haldol, Clozaril are antipsychotics. Parnate, Elavil, Prozac, those are different types of antidepressants. Lithobid and Sibboleth are lithium, and Nembutal and Valium are different types of anti-anxiolytics, as well as Xanax. So, assessing biological approaches. So, when conducting an evaluation, we often look at the role that the person plays, and those who have a disorder and they're given medication really have no role in the recovery process. It's really just the biology of the body that's working. So the treatment is drug dependent and it addresses biological issues. However, sometimes the side effects are worse than the disorder itself, and the role of the environment and psychological processes is not addressed, because many times there are other factors besides a hormonal imbalance that are causing the depression, and just by treating that chemically doesn't necessarily mean you're solving the problem. So then we move to psychological approaches, and the three main approaches are behavioral, cognitive, psychodynamic, and humanistic. We also see family systems and emotion-focused approaches, although they're not as common. Behavioral approaches, there are various different kinds. The first is classical conditioning. So this is where we have paired two stimuli together such that the presentation of one stimuli elicits a fixed response. So if you think about little baby Albert that you learned about in Psych 101, how Watson kind of paired a loud noise with the presentation of his little rabbit, and so when he saw the little rabbit, he just started crying hysterically. So that was classical conditioning. Operant conditioning is shaping behaviors by rewarding desired behaviors and punishing or withdrawing reinforcement for undesired behaviors. So we have different, we'll learn more about this as we progress, but you have different reinforcement schedules. So you have continuous, whereby every bit of behavior is reinforced. Then we know that that doesn't maintain long-term behaviors. Then we move to a partial reinforcement schedule where random trials are reinforced. We have extinction, whereby we do no longer reinforce the behavior, and conditioned avoidance responses, whereby people avoid aversive stimuli and therefore they are rewarded from staying away, but as a consequence you have development of things like phobias, etc. Modeling and observational learning, that pertains to the Bobo doll experiments that you probably all heard about from Bandura. We learn new behaviors by imitating the behaviors modeled by important people in our lives. So people you look up to and respect are more likely to be role models for you, and you're more likely to model behavior for them. We also learn through observational learning, and so we learn by observing the rewards and punishments that another person receives and then behave accordingly. This is kind of the premise behind the criminal justice system. So if we see that other people are punished for these crimes, then we're hopefully not going to commit them ourselves. You probably remember Pavlov's dog, and so we have the unconditional stimulus. That's something that people would be wanting to have anyway. That would be kind of food, sex, things like that. Unconditioned response is the response to the food. So when the dog sees the food, he salivates. So if you then pair the food with the presentation of a person in a lab coat, so whenever food is presented, it's given by somebody in a lab coat. Whenever the dog then sees somebody in a lab coat, it'll start responding to the person in the lab coat rather than the food, and therefore the food becomes now the conditioned stimulus. Different behavior change techniques include removal of reinforcements. That's why when you take away something that's rewarding to somebody. Aversion therapy is a way to make situations or something like they were once rewarding no longer rewarding, because you give a noxious stimuli presented with the reinforcement. You can do relaxation exercises where you help the individual control physiological manifestations of anxiety by conducting, relaxation techniques such as deep breathing. Distraction techniques is when you kind of do things like mindfulness, where you focus on something else aside from things that are worrying from you. Flooding or implosive therapy refers to, if you think about people's phobias, so the fear factor where people were thrown into a cage with lots of spiders, if they have fears of spiders, and eventually you will no longer be super anxious, although the thought of that can be very aversive. Systematic desensitization is when we gradually expose ourselves to our fears, so it would be kind of like looking at pictures of spiders, being in a room with a spider in a cage, being 5 feet away from the spider, being 1 foot away from the spider. And then response shaping through operant conditioning, so pairing rewards with desired behaviors, behavioral contracting, and modeling and observing of observational learning, as we talked about before. So assessing behavioral approaches. They set the standard for scientifically testable hypotheses about how normal and abnormal behaviors develop. Their effectiveness has been extensively and systematically supported in randomized controlled trials. Can account for some disorders, not necessarily all of them. We have a lot of evidence from laboratory studies, but a lot of people criticize behaviorism because it doesn't account for people's free will in terms of their behavior. And so that's why oftentimes you'll hear about cognitive behavioral therapy, where people are including the cognitions or the internal responses that go along with the behaviors. So cognitive behavioral therapists, which is what I am, practice both behavioral and cognitive techniques. So cognitive theories argue that it's not just rewards and punishment that motivate human behavior, but that our cognitions or our thought processes can also shape our behaviors and emotions. So we often give causal attributions to different events, and therefore it gives them meaning. For example, if I'm walking down the street and somebody looks at me up and down, I can think, wow, that person thinks I'm really attractive, and I'll feel good and walk with my head high for the rest of the day. Or I can think, wow, that person thinks I'm pretty gross, and therefore my mood will be negatively affected. But there's no difference in the behavior, it's just my cognitive appraisal of the situation. Oftentimes people who have psychopathology like depression or anxiety have these global assumptions. These are broad beliefs of oneself, relationships, in the world. And oftentimes these are negative or fear-inducing, like everybody's out to get me, I'm going to fail, I'm a loser, nobody loves me, things like that. Or there's no point to anything. So these are global assumptions that people think, but there's not a lot of evidence for them. So cognitive therapies identify and challenge these negative thoughts and dysfunctional belief systems. So through a series of different techniques, we identify some of these negative thoughts that people are feeling, and we work on changing them and modifying them. We help them learn effective problem-solving techniques. They're generally short-term. I'd see patients generally about 15-ish to 25-ish sessions. As I mentioned, cognitive behavioral therapy combines cognitive techniques with behavioral techniques. And the goals of cognitive therapy are assisting clients in identifying their irrational and maladaptive thoughts, teaching them to challenge their irrational and maladaptive thoughts or consider alternative ways of thinking, and to encourage clients to face their worst fears about a situation and recognize ways in which they can cope. So if we evaluate cognitive therapies, they're very useful in the treatment of sexual disorders, substance use disorders, effective in the treatment of depression, anxiety. It's hard to prove that maladaptive thoughts precede and cause disorders. We know that they happen at the same time. We don't know, it's very hard to see which happened causally, so do our negative thought patterns then influence our hormone levels or vice versa? It's not clear whether they're the symptoms or the consequences of the disorder. Our next approach is the psychodynamic approach, in which this is kind of the Freudian approach, in which we think that all behavior, thoughts, and emotions, both normal or abnormal, are influenced by unconscious processes. So this includes psychoanalysis, which is what Freud Freud practiced, and several new approaches. So psychoanalysis is the theory of personality and psychopathology, and it's a method of investigating the mind. And it's a form of treatment for psychopathology. Psychoanalysis is generally very long-term, so people see therapists multiple times a week or psychoanalysts multiple times a week for many, many years. It often is done lying on the couch. It's not practiced nearly as extensively as it once was anymore. There's not been a lot of research evidence, as we'll see later in a few slides, compared to some of the other techniques, and it becomes very costly when you consider the number of times per week and the duration of the treatment. And it's not designed to be short-term, it's designed to be long-term. It's not designed to be symptom-focused either. It's kind of looking at the underlying roots of the behavior. It's still practiced a lot in New York compared to other areas of the world, but generally kind of on the decline. So according to Freud, human behavior is driven by various things. Our libido, which is our sexual drive, our aggressive drive, and then our psyche has three systems. The id, which is the kind of the pleasure kind of seeking part of our personality. It is our drives and impulses, and it seeks immediate release, so it's kind of like the little kid. The ego is the force that gratifies wishes and needs in ways that remain within the rules of society for its appropriate expression. And the superego is really kind of the morality and the mother hen kind of thing, making sure that the id and the ego kind of stay in check. According to Freud, interactions among the id, ego, and superego occur in the unconscious, meaning that they're completely outside of our awareness. We do have some levels of pre-consciousness, whereby we're kind of aware that some of these things are going on. And so what we do when the conscious behaviors try to become more conscious is we use defense mechanisms like regression, denial, displacement, rationalization, intellectualization, projection, reaction formation, identification, and sublimation. These are also described in your text. Freud also talks about the psychosocial stages of change. He talks about the oral, anal, phallic, latent, and genital phases. And the oral phase is the young child, where they're sticking everything in their mouth. They're understanding the world through their mouth. Then in the anal phase is when they're learning to toilet train. Between the ages of 3 and 6, they learn that they're boys and girls, and they start focusing on their phallus. Between 6 years to puberty is kind of the latent stage, so the sexuality is kind of put on the back burner. It's only then as the kid goes through puberty that the genital stage comes to be, and they become kind of adults as they mature. Sometimes Freud would speculate that people who have different kinds of psychopathology never fully completed some of the stages, and so that you'll see that he's stuck in that anal stage or the phallic stage. So more recently, there have been more different kinds of psychodynamic theories, such as ego psychology, which emphasizes the individual's ability to regulate defenses, object relations, which they integrated a significant part of Freud's theory, with the role of early relationships into the development of self-concept and personality, and self-psychology and relational psychology, which emphasizes the unconscious dimensions of our relationships with one another from pregnancy and infancy throughout all of life. So psychodynamic therapies work to help clients recognize their maladaptive coping strategies and their sources of their unconscious conflicts. So it kind of helps to make the unconscious conscious. So they use techniques such as free association, which you've probably seen on TV, where a client talks about whatever comes to mind without censoring anything. They also use things such as transference, and so the therapist often acts as a blank slate, and the patient is reacting to the therapist in an important way, and therefore they're kind of projecting onto the therapist some of the other relational issues they have, and they have to interpret that. And then working through is repeatedly going over painful memories and difficult issues in an effort to resolve them. Interpersonal therapy is actually one of the more, has received a lot of support in its treatment for depression, and it's actually emerged from, it's a modern psychodynamic theory, it's short term, and it shifted the focus from the unconscious conflicts to the client's pattern of relationships with important people in their life. It's much more structured and directive. It looks a lot more like CBT, and it offers interpretations much earlier than traditional psychodynamic therapy, where you could be in therapy for many months and sometimes even years before the analyst starts interpreting your thoughts, feelings, and behaviors. And it focuses on how to change current relationships. It actually gives the patient a sick role. So it says that, while you're being depressed, you can be sick, so you have to be gentle on yourself. And it focuses about, on loss and grief and grieving, relationship losses in an effort to move forward. So when we assess psychodynamic approaches, people feel like some of them are the most comprehensive theories of human behavior, but really a lot of them are very hard to test. I mean, how do you test an id and superego? I mean, there's no such tangible things. How do you test these stages of change? I mean, a lot of this is just theory-based. And the long-term and intensive nature of it makes it unaffordable for many people. Even insurance companies would not pay for something like this. Humanistic approaches are based on the assumption that humans have an innate capacity for goodness and for living a full life. The name that's most often associated with humanistic approaches is Carl Rogers, and he worked on, his therapy was called humanism or humanistic psychology, and he believed that individuals naturally move toward personal growth, self-acceptance, and self-actualization. And self-actualization is defined as the fulfillment of one's potential for love, creativity, and meaning. So in humanistic therapy, the goal is to help clients discover their potential through self-exploration. It's very much client-centered in that the therapist communicates a genuineness in his role as a helper kind of thing. So you're helping the client in their exploration process, and you're really there being kind of more in a friendship capacity almost than an authoritative one. And you always show unconditional positive regard for the client. So you don't show that you're always supportive, and you communicate with empathetic understanding. So when we assess humanistic approaches, the focus on free will is refreshing. It's more positive in nature. However, it's criticized for being vague and not subject to scientific testing. It can be appropriate for people who are moderately distressed, but those who are suffering from more distress probably are not appropriate for humanistic interventions. Family systems therapy is kind of looking at the family as a whole. So oftentimes when people are not doing well, the whole family system is not doing well. Or when a child is not doing well, it's because the whole family system is not doing well. So you look at the family as a complex interpersonal system with its own hierarchy rules that govern family members' behavior. And if you think of your own family, that's probably the case. And it uses family members' psychological disorder as an indication of dysfunction in the family system. So family systems therapy would believe that individual problems are always rooted in interpersonal systems, particularly family systems. So oftentimes the whole family is brought into therapy. It's been effective in the treatment of children because kids are so much more intertwined in families than adults are, but it needs a lot more research. And kind of a newer thing that's kind of developed in the last 10-15 years are called the third wave approaches. These are often focusing on people's ability to understand and regulate their emotions. It incorporates techniques from cognitive behavioral therapy with Zen Buddhism. One of the more known techniques is dialectical behavior therapy. So these are for people, it was initially developed for people with borderline personality disorder who made a lot of suicide attempts, kind of to help them regulate themselves. And so it encompassed kind of feelings of radical acceptance and mindfulness along with behavioral therapy approaches. And it was the first therapy that showed significant impact in reducing suicidal behavior among this population. Another therapy that's developed by Steve Hayes is acceptance and commitment therapy, in that they speculate that avoidance is the heart of all problems, and so the therapy is really geared towards having the person expose themselves to whatever is kind of at the root of their problems. So sociocultural approaches look beyond the individual or family to the larger society to understand the person's problems. They're in terms of risk factors for mental health, like low socioeconomic status, upheaval and denigration of societies, societal norms and policies that stigmatize and marginalize certain groups. So this would be very relevant in developing countries where there's a lot of political and social instability, where large chunks of the population live in poverty. Although we could also use these in, obviously we have those same issues in America as well. And so you want to understand the psychology within the context of the community. And so social norms and policies that stigmatize and marginalize certain groups put these individuals at increased risk for mental health. So for example, discrimination, policies such as segregation back in the day. Implicit or explicit rules about what types of abnormal behavior are acceptable determines the type of psychopathology shown by a member of a society. So our DSM for us is defining what is normal and abnormal, but that defines our role in society. So we have to more and more, as we become increasingly diverse, talk about diversity in our therapy. Psychotherapy here in the Western world values the expression of emotions, but there are certain cultures that restrain emotions, and so expressing emotion would be very counterintuitive for them. Many psychotherapies are also focused on individuals, whereas people may come from collectivist cultures where the individual is not as important as the kind of the collective. I feel like a little bit like the Borg for those of you who are Star Trekians. Clients are expected to initiate communication on expectations, which can clash with cultural norms, but it's really the therapist's responsibility to assess the client and where they're coming from. Class and issues of race pose difficulty in accessing help, and issues of age, different gender, and ethnicity can sometimes hinder treatment. So for sometimes these perceived differences can be overwhelming, and those need to be addressed. And sometimes there's nothing that can be done. And they have to find a new person to work with them, and sometimes these issues can be overcome with discussion. Prevention programs are very important. We have 3 levels of prevention: primary, secondary, and tertiary. So primary is stopping the development of disorder before it happens. Secondary is detecting a disorder at its earliest stages to prevent the development of a full-blown disorder. So it would be kind of finding the symptoms before somebody gets a full-blown disorder. And tertiary prevention is preventing relapse and reducing the impact of the disorder once the disorder has already been expressed. So common elements and effective treatments: having a positive relationship with your client, that's called the therapeutic alliance; providing clients with an explanation or interpretation of why they're suffering, so educating them on their disorder and kind of the etiology or cause of the disorder; encouraging clients to confront painful emotions and have techniques for them to become less sensitive to these emotions. So this is basically an exposure technique, because we find that when we avoid hard things in our lives, that's when they kind of build, and if we don't deal with them, it gets to be uncontrollable, and we can't control the expression.